Hello everyone, welcome to another important topic, that is natural history of HI or hypoxic ischemic encephalopathy of newborn. Now why I should study this natural history? By studying the natural history of HI, I will be in a better position to anticipate what signs or symptoms and complications will appear at what given point of time, so that I can be well prepared in advance and intervene timely. Also, I'll be able to understand whether whatever the manifestations the baby is having are just because of the HI per se, or is there any other evolving disease process that is going on, like sepsis, meningitis, or other metabolic complications like hypoglycemia, hypocalcemia, etc., that are usually seen complicating HI. Today's discussion is based on the textbook Volpe's Neurology of Newborn and other standard text. The evolution of clinical signs and symptoms in newborns with HI is termed as neurological syndrome. As we all know that not all signs and symptoms of HI are present at a given point of time, and the signs and symptoms they evolve over a time. So hence serial neurological examination of the newborns with HI is of utmost importance. We also know that the insult to the neonatal brain can occur not only at birth but also antenatally or postnatally, ending up in HI. Now, to attribute this insult as the main underlying etiology for HIE and its sequelae, 3 points need to be met. That is, there should be an evidence of fetal distress in the form of either fetal heart rate abnormalities, or there should be an sentinel event, or there should be fetal acidosis. There should also be depression at birth in the form of requirement of resuscitation or low Apgar scores, and there should be a overt neurological syndrome in the first hours or day of life. So in newborns with severe HI, in the initial 12 hours of life, the signs of bilateral cerebral hemisphere involvement will be predominant. Baby will be either deeply stuporous or comatose. Baby will be having periodic breathing. There may be respiratory failure, thus requiring mechanical ventilation. Baby will be having marked hypotonia. Okay, and there is minimal movements, if any. Either it may be spontaneous or on stimulation. So tone may be normal in less severe cases. So coming to eye signs, the pupillary reflex will be intact no matter how severe the HI is. That means the brainstem reflexes, the reflexes which are mediated through brainstem, will be intact in the initial 12 hours of life. So the spontaneous eye movements will be present and doll's eye reflex will be full. The pupil size will be variable. In less severe forms, the pupils will be dilated and reactive, whereas in more severe forms, the pupils will be constricted and reactive. So this is because in the less um, severe HIE, there is sympathetic overactivity, whereas in stage 2 or stage 3, it will be stage 2, it will be the parasympathetic activity which is predominant, hence causing the meiosis. So as I said, in initial hours, despite the severity, the eye signs of major brainstem disturbance are usually not seen, as we discussed previously. So what are the eye signs or the brainstem disturbances signs which we will look for? That is fixed and mid position or dilated pupils which are not reacting to light, absent eye movements to doll's eye, and absent eye movements to cold calorie stimulation. If these signs are present in the first 12 hours of life, the brainstem injury is more likely, so we have to think of that rather than attributing it to just severe HIE. So the most, again, an important aspect of HI is seizures. So seizures usually occur by 6 to 12 hours of life in 50 to 60% of the cases. So as I said, the seizures usually do not occur during first 6 hours of life or are very rare. So the usual time of occurrence is 6 to 12 hours. The appearance of seizures is telling you that there is HIE evolution that is going on. So the most common type of seizures are subtle seizures, as we all know in HIE. So in preterms, there may be general tonic seizures, that is, baby might be having decorticate posturing type of movements, whereas in term newborns, it is multifocal clonic. Okay, if focal seizures are there without any signs of without any major signs of encephalopathy, always think of stroke or localized lesion rather than HIE as etiology. So to call it as HIE, then the signs of encephalopathy should also always be there. If ischemic cerebral lesions are there, the focal seizures may be predominant. So just briefing about subtle seizures. They may be either ocular phenomenon or oral, buccal and lingual movements and limb movements or apneic spells. In ocular phenomena, there may be tonic horizontal eye deviation or there may be sustained eye opening type of movements. Whereas in buccal lingual movements, there may be sucking or lip smacking type of movements, as you may have noticed while managing babies with HIE. So the limb movements will be in the form of swimming, rowing movements or cycling type of movements. So seizures in case of babies who are being treated with therapeutic hypothermia. So the onset is usually first 48 hours of life. The median age of onset of seizures is said to be at around 13 hours of life. So, however, the seizures may occur even before that or after that. So, even they may appear during rewarming or even after completion of rewarming, that is beyond 72 hours of life. However, the initial 24 hours of therapeutic hypothermia pose the highest risk for seizures. Now, coming to mild to moderate HIE, the babies will be usually irritable and hyper alert. The spontaneous activity will be preserved, but it will be decreased. So hypotonia is seen with hypotonia in distal limbs, that is cortical fist ring or what we call as cortical thumb. So if there is prominent basal ganglia involvement, it will be of predominantly hypertonia rather than hypotonia, and seizures will be seen only in case of moderate and severe, not in mild, and there may be some respiratory problems in form of respiratory distress. So moving on to the next part, that is 12 to 24 hours of birth, that is the second half of the day 1 of life in case of severe HIE. So baby will be having variable changes in the level of alertness. The baby may seem that the alertness is improving a bit, the baby becomes slightly more alert, but however this improvement in alertness is more of apparent rather than real improvement, because only the alertness is improving, however the visual fixation or other signs of cerebral functions are not improving. So if you see you often see that in the later part of the first day, babies with severe HI have slightly improved alertness, but this is not actually the real one, so it is just the apparent one. So respiration, there may be apneic spells in around 50% of the newborns. Tone, again it will be predominant hypotonia. If there is predominant basal ganglia involvement, then hypertonia will be seen, especially when we handle the babies while handling them. So weakness will be mainly in the hip shoulder distribution pattern in term newborns. It will be more of proximal weakness and it will be symmetrical, though some asymmetry is expected. If there is marked asymmetry, then again we have to think of focal causes like stroke. So the again weakness will be more in upper limbs than the lower limbs, what in future will lead to spastic quadriplegia. Whereas in preterm, it is predominantly the weakness in the lower limbs which is more than the upper limbs. However, in very preterms, it is quite difficult to appreciate in the initial period of life. So coming to seizures, now as we have seen, most of the seizures occur during first 6 to 12 hours of birth in 50 to 60% of the cases. So remaining 50 to 20% of the cases, the seizures may appear during 12 to 24 hours of birth. However, the seizures which have already occurred started previously may become severe. Baby may have multiple seizure episodes. Baby may have status epilepticus and require vigorous therapy. So it is mentioned that maximum seizure burden in case of severe HI is present around 19 hours of life. So that is around at the end of day 1 of life. So again, jitteriness may also be seen in few newborns. So in babies with mild to moderate HI, in the second half of the first day, babies will be still irritable and hyper alert. Again, as we see, increased seizure burden will be there in moderate HI. There may be apneic cells and the hypertonia may be evolving. Now coming to the next day, that is from day 2 to completion of day 3, that is 24 to 72 hours of birth in case of babies with severe HI. Now this is very crucial period, as we have seen in the initial 6 to 12 hours, the signs of cerebral cortical dysfunction are predominating, whereas here the signs and symptoms of brainstem dysfunction predominate. In the early period, we have seen that the brainstem reflexes are preserved, that is the pupillary reflex is preserved, the dorsal reflex is preserved, whereas here all those things will be affected, that we will see in further discussion. And babies who eventually die because of HI, the most common time is during this period, that is between end of day 1 to day 3 of life. Okay, so the most of the babies succumb to HI during this period. So median age of death of babies who eventually die is around 2 days, because this is attributed to delayed cell death. Again, the sensorium will be severely affected. Baby will be deeply stuporous or comatose. Respiration will be ataxic breathing, and babies may go into respiratory arrest. So as I said, brainstem disturbance are more common during this period. Pupils will be fixed and mid dilated, and Doll's eye reflex may be absent. However, in few babies, ocular bobbing may also be seen. In preterms, severe IVH may be seen, and which may lead to catastrophic clinical deterioration. So, in cases of babies with mild to moderate HIE at 24 to 72 hours of birth, there will be variable change in level of alertness, and now whatever the hypotonia was there is going to evolve into hypertonia. Now coming to babies with severe HIE beyond 72 hours of birth. As I said, the most common time of death, that is most commonly the babies die during day 2 to day 3. So if they make up through this period, then they usually survive and usually improve. However, the rate of improvement may vary from baby to baby and depending upon the severity. So it may take next few several days, or even it may take weeks. So sensorium, we can see there is dramatic improvement in the level of alertness. However, baby is still stuporous, and it may persist for even several days. Now one may think that babies other things are improving, but still baby is lethargic and stuporous. So you may get confused that baby may be having ongoing other disease process like meningitis and all. So we end up in doing additional investigations. However, this is a natural course of HIE. So tone, again, hypotonia will be more common than the hypertonia, especially, and hypertonia especially in response to handling will be seen if there is predominant basal ganglia uh, involvement. So again, weakness, term babies proximal weakness symmetrical, and upper limbs more than upper limb involvement more than lower limbs, and in preterms it will be lower limbs more predominant than upper limbs. Again, an important aspect during this period, that is beyond 72 hours of life, is the feeding problems. Now the baby has been stabilized, so we start plan to start feeds. So we come across feeding problems very frequently. This is because of decreased power and coordination of the cranial nerves, especially your 5, 7, 9, 10, and 12. There will be sucking, swallowing, and tongue movements in coordination will be there. So especially this is seen in babies with significant deep nuclear type of injury, that is basal ganglia thalamus and brainstem pattern of injury. The feeding problems are extremely common. So baby may require tube feeding for weeks to months, and also pooling of saliva may be seen. In babies with mild to moderate HIE beyond 72 hours of life, there will be significant improvement in level of alertness. The spontaneous movements will improve. However, there will be still feeding problems in moderate HIE. The tone abnormalities will become more obvious now, and it will be readily elicited, especially in moderate HIE. In mild cases, the tone may revert back to normal and the tone examination will be normal. However, there may be some amount of residual truncal hypotonia. The infants with fastest initial improvement, which we have observed, or infants who are having essentially normal neurological examination at 1 week of life, usually have a good neurological outcome. Now, summarizing the events in babies with severe HIE, in less than 12 hours, that is 6 to 12 hours of life, the baby will be deeply stuporous or comatose, and by 12 to 24 hours, we have seen there is variable alertness, that is, there is apparent improvement in alertness without simultaneously improvement in other cortical functions. And between 24 to 72 hours, the baby will be having worsening of the stupor or coma, and the babies who survive beyond the 72 hours period will be having improving alertness. However, some amount of stupor may be persistent. Coming to the respiratory uh, findings, babies will be usually having periodic breathing or respiratory failure requiring mechanical ventilation below 12 hours of life. Between 12 to 24 hours, there will be increasing amount of apneic spells, and by 24 to 72 hours of life, respiratory arrest may be seen. Seizures we have seen, most commonly they are seen during 6 to 12 hours of life, and over the next 12 hours, the seizure burden increases, and they become very frequent and more resistant to treatment requiring vigorous therapy. And beyond this, that is day 2 or day 3, seizures may be controlled with medications, and baby who survive beyond 72 hours of life, seizures usually decrease. However, in babies with therapeutic hypothermia, rarely the seizures may reappear during reforming. So this one has to anticipate in advance. Coming to brainstem and pupillary reflexes, in the first 12 hours of life, usually the brainstem reflexes are preserved. That is, the pupillary reflex is present, dorsal reflex is present, uh, and during the 24 to 72 hours of life is where the major, mainly the brainstem dysfunction manifests, and it is in the form of fixed mid dilated pupils and absent dorsal reflexes. And babies with in and beyond 72 hours of life, babies will be usually having feeding difficulties. Now coming to babies with moderate to severe HIE, mild to moderate HIE, we'll see the what will be the sequence of events. So less than 12 hours, babies will be usually hyper alert or irritable, so which will be persistent for the next 12 hours. Between 24 to 72 hours, there will be variable alertness, and beyond 72 hours, the alertness improves, and also the spontaneous activity also improves. And in respiration, there will be initially some disturbance in the form of respiratory distress. Apneic spells may be seen in the next 12 hours, that is 12 to 24 hours in moderate cases of HI. Coming to seizures, as we have seen, most commonly between 6 to 12 hours in case of moderate HI. Let us remind that mild HI doesn't have seizures. If seizures are present, then automatically it falls under the category of moderate to severe HI. So over the next 12 hours, the seizures increase in number and frequency. So jitteriness will be increasing, and beyond 24 hours, the seizures are usually controlled. Coming to tone abnormalities, less than 12 hours, the usually it will be hypotonia and with the distal hypertonia, that is cortical thumb or cortical fisting. 12 to 24 hours, slowly the hypertonia evolves in case of moderate, whereas the tone abnormalities usually they revert back to normal in case of mild HI. So 24 to 72 hours, there will be again evolving hypertonia, and beyond 72 hours, usually the tone returns back to normal. However, there is some residual truncal hypotonia. So, after understanding the chronology of events in babies with HI, let us try to understand the staging of newborns with HI. So, there are many staging systems that are being proposed. That is Sarnath and Sarnath staging is there. There are multiple modifications to this Sarnath and Sarnath staging system. There is Thomson staging system. So there are many staging systems. So more or less the components of the systems remain the same. So we'll try to understand the components and so that we can apply them bedside. So coming to stage 1 or mild HI, stage 2 it is moderate, and stage 3 severe. So in stage 1 the babies will be hyper alert, whereas in stage 2 babies will be lethargic, and in stage 3 babies will be usually stuporous or comatose. The spontaneous activity will be normal in case of stage 1, decreased in stage 2, and will be absent in stage 3. In stage 1 babies will be having mild distal flexion, whereas in stage 2 there will be strong distal flexion, and in stage 3 babies will be decerebrate. In stage 1 the tone usually is normal. Even if abnormality is there, it will be usually transient and it will revert back to normal. In stage 2 it is usually the hypotonia, whereas in stage 3 babies will be completely flaccid. The coming to important aspect, that is the primitive reflexes. In stage 1 the suck reflex will be weak, whereas in stage 2 it will be either weak or absent, and in stage 3 it will be absent. Coming to Morus reflex, it is strong or exaggerated in stage 1 and will be having a lower threshold, whereas in stage 2 it has a higher threshold, it will be weak and incomplete, whereas in stage 3 it is absent. Now coming to autonomic signs and symptoms. So before understanding all them, let us understand the concept that in stage 1 usually there is generalized sympathetic overactivity, and in stage 2 it is a parasympathetic system which is predominantly activated, and in stage 3 both the systems are depressed. So from our pharmacology knowledge we know that sympathetic stimulation will cause dilatation of the pupils, increase in heart rate and decrease in secretions, whereas a parasympathetic stimulation will cause constriction of pupils, bradycardia and increased bronchial and salivary secretions. So now applying this knowledge, we'll see pupils will be dilated or there will be mydriasis in stage 1. There will be constricted pupils in stage 2, and the pupils will be unequal or and sluggishly reactive in stage 3. The heart rate will be, baby will be having tachycardia in stage 1. In stage 2 there will be bradycardia which is predominant, and in stage 3 the heart rate will be variable. Now coming to bronchial and salivary secretions will be sparse in stage 1, and in stage 2 parasympathetic mediated profuse secretions will be there, and in stage 3 again it will be variable. The GI motility also is decreased or normal in case of stage 1. In stage 2 it is increased, so baby might have diarrhea, and in stage 3 it is again variable. Now coming to seizures, again an very important component. In stage 1 it is absent, so any seizures, either it is stage 2 or stage 3. So seizures are most commonly seen clinical seizures are most commonly seen in stage 2. Stage 3 also seizures are seen, but they are usually uncommon. EEG abnormalities in stage 1 it is usually normal. Stage 2, low voltage continuous delta and theta activity is seen. There is also periodic pattern will be seen. In stage 3, either periodic or isoelectric pattern will be seen. So hope you understood the concept of natural history of HIE and the basis or the underlying physiological basis for staging of HIE. So meet you in the next video. Till then, happy learning.